Good afternoon, everyone. My name is Glenn Keeling. I'm the administrator for HipecTreatment.com, and I'd like to welcome you tonight to our Hipec Facebook live event. With our guest presenter is Dr. Leonard Henry, who is the medical director of the Goshen Center for Cancer Care in Goshen, Indiana. Until some questions start coming in, Dr. Henry, I'd like to ask you a couple questions here. Could you tell us a little bit about Hipec at Goshen Center for Cancer Care and your background in Hipec and basically the types of cancers that you treat?
Yeah, sure. So thanks, Glenn. Thank you. Welcome, everybody, if you're on. But again, I'm Len Henry. I'm a surgical oncologist. I've been a surgical oncologist, finishing my fellowship training in 2005 in Philadelphia. And then I was on staff in the Navy for 5 years at Bethesda, now the Walter Reed National Military Medical Center, for 5 years after that. And then left the military and came to Goshen, Indiana, where I've been now for 11 years. And so our Hipec program, my interest in Hipec began when I was in the military. And actually, my initial experience with Hipec was while I was in the military. But since being in Goshen, we started a program. I think we did our first case in 2011, so 10 years ago. It's generally gone well. You know, we're a smaller cancer program in the South Bend metropolitan area. Precious few centers in Indiana do this. There's been periods of time where we've been the only center in Indiana to offer it on a routine basis. So it kind of comes and goes with, based on what the competitor programs are doing. So our program in Goshen, we have a group of surgical oncologists, and so we tend to isolate our practice a little bit by organ site and tumor site. So my practice, in addition to peritoneal surface malignancy, includes kind of a unique group of operations. I like to do thyroid and parathyroid, so I do quite a bit of those, and then mostly, GI related things, including cytohypec on top of that. So that's typically what my practice looks like. Hope that helps folks.
What types of cancers do you see in treating Hipec, in administering Hipec?
Right, the typical ones would include appendix, obviously. There's lots of different varieties. There's several different varieties of appendix cancer, and we generally perform cytoreductive surgery on just about all of them. There's some small differences in the approach, whether it's preoperative chemotherapy based off tumor grade and things of that nature. But appendix is a big one. Even though it's a rare cancer, they tend to collect in centers that have experience dealing with appendiceal cancer. A fair number of colorectal cancer patients with peritoneal disease, as long as it's limited to the peritoneal surface or very few extraperitoneal sites, like a couple liver metastases, would probably be still acceptable for us. But colorectal cancer is a fairly common indication for cytoreductive surgery in Hipec. Peritoneal mesothelioma is traditionally, at least now, I think standard of care is to include cytoreductive surgery in Hipec for the subtypes for which it's indicated. The majority of peritoneal mesotheliomas are the epithelioid subtypes, and those are suitable for cytoreductive procedures. Those are fairly rare cancers, but again, they tend to collect in centers that have a reputation for cytoreductive surgery in Hipec. A little bit of experience in ovarian cancer. We have GYN oncologists who drive the GYN oncology program. So it is largely at their discretion to employ cytoreductive surgery in Hipec. I don't get a lot of referrals for ovarian because of our GYN oncology program. And then some recommend it under fairly strict circumstances for gastric cancer patients. I have not done a lot of those. The peritoneal, the limitations in that cancer, the peritoneal burden has to be so small that we don't see that very often. So those are the biggies: appendix, colorectal, mesothelioma, peritoneal mesothelioma. Some do it for pleural mesothelioma as well, I should mention. Big program in Boston that does a lot of what they call HITECs, heated intrathoracic chemotherapy. But mesothelioma, in addition to appendix, colorectal, ovarian, and the rare gastric cancer patient.
Dr. Henry, what are the important factors in determining if a patient is a candidate for cytoreductive surgery and Hipec?
Yeah, that's a really important question. So I think there's three big things that I consider, which I think is pretty standard. I think most surgeons would consider. The first is the suitability of the patient. It's a fairly demanding operation for the patient. They can be very long. The hospital stays, our average hospital stay is 9 days, but certainly they can be longer and occasionally they can be shorter. So the patient fitness, overall functional status, very important. So for instance, we use a performance status, and typically we would only offer cytoreductive surgery and Hipec for people with performance status of 0 or 1, and nothing more than that. What that means is the higher the number is basically the worse the performance status for the patient, and the expected outcomes or complication profile would be worse with the higher number. So the second issue that typically comes up is the biology of the disease. And so if the tumor is the right kind of tumor, we pay a lot of attention to tumor type or grade. In certain circumstances, we select patients based off of what we call a proliferative index of how fast the tumor cells appear to be dividing. Employ that for peritoneal mesothelioma patients. The underlying biology of the disease is very important, probably the most important, or, besides the fitness of the patient. And then the last thing is technically, can you do it? There are certain findings which we see on imaging. Maybe the volume of disease for the tumor type is not suitable, or the tumor distribution looks like you might not be able to perform a complete cytoreduction. And complete cytoreduction, I mean, you have to be able to remove everything down to about 2.5 millimeter deposits. And so usually the limitations have to do with the small bowel, if you're able to clear the small bowel or not. So I often do a laparoscopy before, because the imaging today, even though it's excellent, is not able to really identify small bowel implants at that size. So laparoscopy can be very useful in those circumstances, where we actually just put a camera in and observe the loops of small bowel to determine whether or not we think a complete cytoreduction is feasible. So those three things, really, it's the biology of the disease, the fitness of the patient, and then the technical ability to do the cytoreduction. A lot of that's based off of tumor volume, and that can be, and there's different kind of volume thresholds for different tumor types.
Okay. A question coming in from the audience. This deals with LAMN patients.
Mm-hmm.
Localized disease after the appendix has been removed. Some surgeons believe that cytoreductive surgery and Hipec is overkill, over-aggressive approach. What would be your opinion on that?
Yeah, for me, I think, one thing about lamins, one of the big discriminating things that I try to determine, you can't always, is the cellularity of the mucinous deposit. So I would tend to be more aggressive if the peritoneal implants, and we're talking just around the appendix, the right lower quadrant, I assume, because if they were outside of that, I would generally recommend cytoreduction and Hipec for those patients. But if it's just periappendiceal and in the right lower quadrant, I think it's important to know the cellularity of them. There's absolutely no, in my estimation at least, I don't think for lamins, low-grade appendiceal mucinous neoplasms with a low volume of mucin in the abdomen, I certainly don't approach those in an emergent fashion. I've had several patients who we know have mucinous implants that we've watched for several months to see what the disease biology would look like. So as time goes by, I think especially in the setting of recurrence too, like say they've had a Hipec and they've recurred, I tend to watch to see what the volume of disease is going to be or how fast he's growing before we submit him to a second Hipec, which we've done several times. So yes, this localized right lower quadrant mucin, in my mind, if it looks acellular, I would probably watch. If it's cellular and they've never had a cytoreduction Hipec, I'd have a discussion with the patient about the pros and cons of going ahead at that time versus waiting and seeing what the disease biology shows over time. Some people can have mucinous implants that just hang out and don't really do much for a long period of time. And I think it's important, understanding that a lot of these are going to recur. The majority are going to recur, even after a cytoreduction of Hipec. So the art of medicine, I think in this case, is buying as much time for the patient between operations as possible. So that's how I've kind of shaped my practice here, is to, especially with lamins, is to be a little slower to the operating room than with other tumor types.
Okay. How do you watch these? Do you laparoscopically look at these, or do you go by the scans?
If you can see it on the scan, so we use MRIs, which show mucinous deposits much better than I think CT scanning does. So that's important, I think, for your patients. If you're being followed with CT scans, I think it's superior to use MRIs. So that's what we use. So if they can be seen with MRI, we also use tumor markers, though they're often not elevated. We use a variety of tumor markers, actually. I follow 3 different types of tumor markers. But yeah, if it's seen on MRI, that's a great way to follow. The hard part about laparoscopy, from my perspective in following patients, I tend to use it if I'm concerned that they've got a recurrence that I don't know about, but I have not employed, routine scheduling of laparoscopy to survey patients. My impression has been, if it's so small that we can't see it on the imaging, it's probably not, and especially with lamins, it's probably not clinically significant enough to operate on, even if you found it. So my approach has been, I haven't used a lot of laparoscopy for screening or for surveillance, so to speak.
Okay. What are the expected outcomes of cancers with a Hipec procedure, cytoreductive surgery and Hipec? Mm-hmm. And as far as lamin is concerned, what is the recovery process with Hipec as opposed to other forms of treatment?
Yeah. Expected outcomes with lamin should be very good. Lamins are staged, but so for instance, some lamins, if the appendix is not ruptured and there's no spread outside the appendix, technically, if it's an in situ lamin, there should be 0 risk of recurrence. I do tend to follow those patients regardless, because of the inexactness of medicine, where do you trust the surgeon who did the appendix that really didn't perforate it or really looked everywhere for mucinous implants? I tend to follow them anyway. So they can range depending from expected never to recur for localized lamin confined to the appendix versus a patient. Sometimes when the pseudomyxoma is identified, it can be pretty extensive. So there can be a belly absolutely filled with tumor. But if complete cytoreduction is obtained with a lamin, my experience has been variable about how they do long-term. I've had anything from now 8 years of a patient without any evidence of recurrence. So knock on wood, I start to think in terms of, cures for people like that, versus others who the biology seems to be a little more variable. And this is regardless of their completeness of cytoreduction operation that they had. So even with a complete cytoreduction, sometimes we see recurrences. I would say it's typically at that 2-3 year mark where you start to see them, perhaps sometimes maybe a little bit earlier, maybe 2 years, where you start to see them. And again, I'm very slow to reoperate on those if it's a small volume in a non-critical part of the body. I've followed some of those folks with interval imaging for up to several years without reoperating. So it's a high, sorry, somebody's calling me, but they hung up. So it's highly variable, case by case basis, but the outcomes for lamins generally pretty favorable in the world of peritoneal disease. I think it's important for people to understand that, peritoneal cancer historically has been a very difficult, challenging problem. And to talk in terms of multi-year survivors with certain peritoneal tumors, is really an advance, I think, in my mind.
Dr. Henry, you told us about the patients that qualify for Hipec. What about patients? What are disqualifications of a cytoreductive and a Hipec?
Yeah. So fitness of the patient for it would have to be one factor for sure. In our series here, our complication profile. Now, we never age discriminate in operations. Age is a number. It's really more their functional status. But I have noticed that the complication profile goes up with the more elderly patients. So I'm a little hesitant for folks over 70. I wouldn't exclude someone. I mean, if they were over 70 but look great, I mean, I still think they're a candidate. But the fitness of the patient is a big component of who should or should not have cytoreduction Hipec. And beyond that, there are some volume constraints that we pay attention to. Certain tumors should be of a certain volume. It doesn't really apply to lamins. I mean, the belly can be chock full of tumor, and I'll still try to cytoreduce completely those patients. But for instance, colorectal cancer, we use a scoring system to judge the volume of disease in the abdomen. If the volume of disease is of a certain number, we know that those are associated with worse outcomes. So I do break those rules sometimes, I'll admit. So volume of disease, biology of disease, very hesitant towards signet. There's a certain subtype of cancer called the signet ring. Generally speaking, that those indicate a more aggressive biology. The higher grade tumors, a little bit slower to offer operations for those patients. The higher grade tumors and those with signet rings, generally we submit to systemic therapy to look for a tumor response beforehand. But if the biology of the tumor looks as though it looks very aggressive, then I'm a little less eager to offer cytoreduction and Hipec. So I think those are the big things. I would say, again, it's the fitness of the patient, the volume of disease, technical ability to get a complete cytoreduction, and the biology of the disease, which are the things that are considered indications for, and on the flip side, they're considered contraindications or indications against doing cytoreduction and Hipec.
A patient goes through cytoreductive surgery and Hipec. What is the quality of life factor after the procedure?
Well, initially, again, the hospital stays can be a little longer than an average big operation. There's all this stuff out there which people talk about, the mother of all surgeries, and there's this sense that these operations are, horrific for patients. Honestly, it's widely variable how patients tolerate them based off of the amount of stuff that has to be done. So if you have a low volume patient that has a fairly small cytoreductive portion of Hipec, the implications for them are much less than someone whose abdomen is completely filled in with tumor. But regardless, even with big cytoreductive procedures and Hipec, quality of life eventually, literature shows, should eventually go back to baseline. So that takes a little bit. I generally tell patients that at 3 months post-op, they should not notice any difference in their quality of life than before. That first month or 6 weeks is a little tough for patients, even when they're out of the hospital. A lot of people complain of fatigue, poor energy, poor appetite. We generally tolerate up to we generally expect some weight loss. Appetite's poor, food doesn't taste great, energy is not good. My sense is that turns around 6 to 8 weeks or so, and people start to gradually make that functional recovery back to to their normal pre-baseline status.
Obviously, this is a huge surgery. How long does it take for a surgeon to really be good at cytoreductive surgery and Hipec?
Yeah, well, I mean, I think you're always learning. From my personal experience, I don't know if there's any literature on the learning curve for cytoreduction Hipec. I would think, I personally think it's probably somewhere around 50 or so before you start to really feel like you've seen what maybe there is to see in this type of operation, or you're comfortable with or you've developed some the little techniques to get tumor out of the difficult places. So yeah, I don't think it's a time issue, although I do think it helps to be accustomed to doing big operations. So I think if you're a surgical oncologist or other type of surgeon who is used to doing multivisceral resections, or has a lot of experience doing big, liver, pancreas type operations, I think the learning curve is probably less than, for instance, say someone coming right out of training who wants to take it up but has not had a great deal of experience doing big operations. But for me and my, the way I feel about Hipec, I'm not sure it's a matter of time. I think it's a matter of number of them that you've done. I don't know what the literature says on that particular issue, but I think it's a significant number that you need to do before you start to feel fairly comfortable with what you're going to find.
Now, does Hipec eliminate the chemo administrations in the abdomen? Does it eliminate the side effects of the chemotherapy, such as hair loss, etc.? The administration this way? Right.
Yeah. Of course. Yeah. So that's really one of the theoretic and real benefits of Hipec is delivering the chemotherapy into the peritoneum. The systemic absorption is far less. It's not zero, but it is far less. And the drugs that are used are becoming a little more standardized. So what we see mostly from side effects are the occasional drop in white count. Occasionally we have to give someone some, Neupogen or something while they're in the hospital to bring their white count back. You see some low platelet counts from time to time, but no, as far as prolonged nausea or vomiting for a prolonged period of time, or hair loss or horrible diarrhea, that some of the side effects that people might associate with chemotherapy, those are not things that we routinely see. What I see typically is the occasional impact on hematologic parameters like your blood counts.
Okay. Question coming in from the audience: what advantage does Goshen Center for Cancer Care offer its cancer patients?
That's a loaded question. This is my chance to advertise, really. So what advantage? So if you live in this part of the world, so I think the big advantage is the surgical expertise. This is a cancer center that has dedicated cancer surgeons, surgical oncologists. So in Indiana, for instance, there are precious few surgical oncologists, and we have the largest group of surgical oncology specialists in Indiana. At least we have. I'm not sure where Indiana University is with their numbers anymore, but there's very few surgical oncologists, and they're concentrated, at least in the north half of the state. They're all in Goshen. So that's a big advantage. So the other is for the really big cases here, we have a fellow who does these operations with us, but we've set the schedule so that if there's a really big complicated case, sometimes we can have two surgeons involved, and that helps out a lot. So two brains are way better than one. They're like 10 in the operating room trying to think through things and trying to conduct difficult operations. So we occasionally team up on cases. So that's the surgical expertise side. And I think beyond that, the model of care here is very unique. It is kind of university built or university like. We have disease teams to try to get a higher level of specialization and expertise in certain tumor sites. Almost everyone is prospectively discussed in multidisciplinary conferences. So you don't run into a situation where, if you're referred to a surgeon first, you get an operation, and then the surgeon sends you somewhere, and then the medical oncologist sends you somewhere. So we generally like to make our treatment plan up front with everybody involved before anybody does anything, because whatever we do has implications on their care as well. And the third thing I would say is unique about Goshen is our model, which is really to try to take care of every problem of every patient with cancer. So instead of just coming for cancer care, we really have tried to structure the program to solve people's problems. We understand that people with cancer have other things going on in their life as well. So There's financial anxieties associated with cancer treatment, which is very expensive. A lot of people want to try complementary things. A lot of people are taking supplements. People are very concerned about what they eat when they have cancer. And because of that, our program is structured so that all patients with cancer have access to expertise in those areas. So we have on staff naturopathic physicians to talk with patients about their supplements and what they're thinking as far as other types of treatments. We have dietitians, we have mind-body counselors, try to help people navigate through this. We have financial counselors, all of those things, because we're trying to address all the problems that a patient with cancer might have. So I think those are the big unique factors about our program, which I'm pretty confident in saying is very much different, at least in the region, compared to other programs. Not that they're not good programs. I'm not saying that. I just think this is how we built ours, and it is fairly unique in those ways.
Dr. Henry, a question coming in from the audience. Patient had Hipec and was left with a small tumor that could not be removed because it was on a major bloodline. Now it had grown and she's on chemo again. Can Hipec be done again? Repeat Hipec, basically.
Yeah, repeat Hipecs, they certainly can be done again. The question would be if the tumor if there's a tumor that's there that was not resectable the first time around, if you make an assumption that it wouldn't be resectable the second time around, we generally wouldn't recommend actually the perfusion with chemotherapy if there's a large portion of tumor left behind. So the outcomes are best if the tumors can be completely eradicated. So for a patient, now I don't know anything, who this person's Hipec surgeon was, but if there's a question of whether or not that tumor can be resected, for instance, I would factor in a lot of different things. How long has it been since the last Hipec? Is it the only spot? Is the disease biology slow and indolent? And if all those things line up, we tend to increase how radical, at least I do, how radical I would be willing to be. So there's an old, and what I mean by that is, not necessarily in peritoneal surface disease would one consider resection of a major blood vessel to eradicate a tumor, but there are disease sites where that occasionally is required. Sarcomas, for instance, that's not totally uncommon kind of circumstance to have. But it's sort of, in the Hipec world, most people would think that resecting big blood vessels is probably not reasonable, given the disease biology of peritoneal spread. But that being said, if it's been many years since the Hipec and it's the only site of disease, and can the vessel be reconstructed? Does the place have the expertise to do that with vascular surgery and so forth? I would only consider a repeat operation for complete resection of the tumor in the absence of any other tumors that were around. So the question really becomes, some surgeons have different ideas about what resectable is. So if there's a question about that, you might want to get a second opinion and see if that tumor is felt to be unresectable by other surgeons. They might have different opinions about that. There are other options for treatment if it truly is unresectable. I wouldn't think there'd be a huge benefit to opening the abdomen and perfusing it with chemotherapy in the absence of being able to resect everything that's visible for the most part. So I wouldn't recommend going that way. But there are other things that potentially can be done. Radiation techniques can be used, things of that nature to try to control the disease. So hopefully that's helpful. Sounds like a tough problem.
Okay, another question coming in, and I guess this will be the last one. How do they contact you if they want a second opinion, if they want an opinion?
Oh, that's a good question. If they want to come and have a second opinion, they can either email me directly and I'll arrange it. That is lhenry, LHENRY, at goshenhealth.com. Or they can just call Goshen Center for Cancer Care. And we have intake people who, once they talk to you on the phone, that phone number is 574-364-2723. 574-364-2723. The intake people will, once they have your permission to collect records, they will collect everything, all the imaging. You don't have to run around. They will collect everything, make a little chart, which I can review, and then we get you scheduled.
Okay, Dr. Henry, it doesn't appear to be any more questions coming in. I want to thank you very much for your time and your great presentation. And I also want to thank the audience for attending Dr. Henry's Hipec Facebook Live event. Thank you very much and have a great evening, everybody.
Thank you.